Hello? Hello? It's working. Okay. Good morning, everyone. Let's get started. If people want to grab their coffee or water and whatever, so we can get started. We already have a few people on Zoom. Well, thanks very much for joining this satellite session on effective coverage. My name is Agbessi Amouzou. I'm from Johns Hopkins University, and I also work for the Countdown to 2030. I'll talk about it in a few minutes. This session is about measuring effective coverage and quality of care to improve the health of women, children, and adolescents in low and middle income countries. Let me give you a quick run of how we would like to organize things here. Well, in a few minutes, we'll give you a quick intro slide on who we are organizing this session. And then we'll present a little bit about method of effective coverage. This is a concept that has been around for a while, but it's still new. And then we'll talk about some examples, case studies that we have done on family planning and integrated management of childhood illnesses, how you measure coverage, effective coverage using those. And we'll open up for sessions. I think we'll have time for coffee break or bio break. And we've reserved time for small groups discussions. And we think that's a place where really we'll try to create more interactions and have you participate more in helping us move this concept forward. And also another good thing, exciting plan we have is a panel discussion of experts in this area, and then we'll go into closing. So a few housekeeping points. So as you know, this is a hybrid section, meaning we have people on Zoom and in the room in person. So we would like you, if you want to ask questions, it's important that you use the microphone. So we have a number of microphones around that will be going around. And so make sure you speak on the microphone so that those on Zoom can hear you. We really want this section to be really interactive, and we've reserved Q&A sections, and question and answer sessions. After a series of presentations, we'll open up for these presentations. And if you're on Zoom, the chat is available. Use the chats. We'll be monitoring the chat and to make sure that we catch all the questions and comments coming up. And also, we would like to kindly ask you to mute yourself if you're on Zoom, so that we can keep the conversations going. All right. Who are we? So you'll know on the flyers that notice on the flyers that a session is being organized by the Countdown to 2020 and the Improve project. So the Countdown to 2030 is actually a network or a partnership with a mission to provide evidence for advocacy, planning, and accountability in the area of IMCI, reproductive, maternal, newborn, and child health and nutrition. And we focus on really doing in-depth analysis, advanced analysis with countries, and by doing so, we really aim to build our strength and capacity at country level. But our focus, although we work on different outcomes, including impact outcomes such as mortality and others, our main focus has been on coverage, on understanding and monitoring the coverage of RMNCH and N interventions, understanding inequalities in these areas and the drivers of coverage. And so we have been especially focused on using the empirical data that's available at country level, and to let the data speak. It is a group of institutions, academics, doing the analysis, but working closely with countries. In countries, we have we work with public health institutions, research institutions that join with ministries of health for in-depth analysis. We work with several academics, and most importantly, at global level with the Global Facility, Health Financing Facility, GFF. And so right now we focus on GFF countries for a one-on-one analysis and capacity strengthening, and as well as UN agencies to take the analysis and evidence be generated forward. Then the other group is the IMPROVE project. The IMPROVE project started as a component of the Child Health Epidemiology Research Group, CHERG, as an activity of the CHERG group, focusing on really trying to understand the validity of the coverage measures. And so the group has been there trying to validate coverage of key indicators, and led by Dr. Melinda Munos, who you'll hear about from her in a few minutes. And so it used to be improving coverage measurement, and until recently it was renamed IMPROVE. I think IMPROVE is just as it is, improve. It's not the meaning of any acronym, but the aim is, as I said, we're trying to improve the measurement of coverage as well as helping a program design. You'll see the link. The link is put there, and supplement that have been issues that present the papers for validation papers. I think we have some papers, some of the books there. Please take a look at them. Also download them online if you like the online versions. So let's go give you a quick intro about effective coverage. So as part of Countdown, one of the key, as I mentioned, is tracking and monitoring the coverage of interventions. And one aspect of that is monitoring the coverage of what is called the continuum of care. That goes from preconceptions, conception, all the way to child health. And one of the flagship graph is this, which many of you may have seen already, is this continuum of care chart that looks at interventions, indicators along the continuum of care, and we are able to see how coverage level, the coverage level along the continuum of care. Now, this is interesting to see because we look at family planning, and then around delivery, then post-delivery, postnatal care, immunizations, and child health, and you could see where we have the high and the lows and so on. But interesting here is that many of these indicators that we track are related to contact, only express the contact of the women, of children with the health systems, and antenatal care, skilled delivery, and so on, and don't really tell us about what the women actually receive in terms of the quality. And as part of that, we are also seeing some kind of discrepancy between what the measures of impact, such as mortality and the coverage. We have instances of coverage reaching 90%, but we still have maternal, neonatal, and child mortality is really high in these countries. So the question then become how do we ensure, that these measures reflect the quality that women and children receive. So that's where the concept of effective coverage came about. You will see many way of calling it. It's some call quality adjusted coverage measures, effective coverage. There is still a range of terms out there, but the key idea here is to ensure that the coverage, what we call about coverage, reflect the quality that women and children have received. And in trying to do that, we thought about the cascade. So when a program is delivered, you can think about, at what point can we ensure that women receiving a program or intervention get the full benefit of these programs? Well, there are a number of obstacles that along the way. And so if you think about it, a cascade approach, this goes from all the population needs, women needing a special services or children with a specific service, then a number of challenges they have to go through to receive the full benefit of the intervention that they need. They'll need first to visit the service, a health service, or have a contact with the service. Then the service that they have contact to must have the necessary commodities or what we call be ready to deliver that particular interventions, right? So at this stage, maybe the service is not ready, women go into facility, but the facility is not ready to deliver antenatal care or deliver babies and so on. But then when they pass these steps, well, they must receive this health service. So the facility might be ready, might have all the equipment and commodity, but there has to be somebody there really able to deliver the service to them. And then delivering the services according to what we want as the quality, that is delivering according to the standards. And once the service is delivered according to the standard, then the recipient must also abide to the prescriptions. That is the user adherence. Then, when all this happen, then we can now quantify the full benefit of the services received. And so, as you can see, the cascade approach helps us understand the size of the loss across along the way to reaching the full benefit of health benefit for services. And this also helps us understand that it's not just about contact, it's important to also factor in the content and the quality. And the gap between the contact and the quality can be, in some instances, very large, depending on the issues that are highlighted in green here. All right, so this is just to give you a quick overview of this, if I can get this to move. Oops, looks like it's frozen. Okay, all right, good. Thanks so much. So now we'll talk about methods for measuring effective coverage, and you hear about Dr. Melinda Munos, who is assistant professor on Johns Hopkins university and also lead the Improve project. All right? Melinda, come over. Thanks.
Thank you. All right, thank you very much, Agbessi. Good morning, everyone. It's lovely to see you here and to have everyone online. As Agbessi said, I am going to present some recent work that we have been doing to refine the methods for estimating effective coverage, and in particular to sort of develop an evidence base for some of these methods. So I don't want to repeat what Agbessi has said, but just to emphasize that intervention coverage is something that is useful. It is primarily measured through household surveys, and household surveys really aren't designed to capture service quality. And so that's not something that service quality historically has not been included in traditional measures of intervention coverage. And so effective coverage aims to incorporate quality to better understand what proportion of individuals, which individuals are receiving services with sufficient quality to see a health gain. So again, here you have the effective coverage cascade. And the two sort of aspects of the cascade that we have been focusing on most are likelihood of service, sometimes called readiness adjusted coverage. This is the proportion of individuals in need of a service who visit a health service that is ready to provide that service, that has everything they need. We've also focused on quality adjusted coverage, the proportion of the population in need who visits a health service and receives the service according to standards. The reason we focused on these two is that typically the data that you need to measure these isn't available from a single source. Often we have to pull together multiple sources of data to try and estimate these. And so we became interested in how do you do that in a way that is valid. So when we think about estimating readiness and quality adjusted coverage, what we're usually doing is using data from household surveys as well as facility data. And so these two measures, input and quality adjusted coverage, take advantage of the relative strengths of these two data sources. So household surveys are pretty good at providing us with reasonably valid population-based estimates of whether care was sought for individuals in need and the type of facility that was visited. Importantly, they also allow for equity analyses. Facility data, on the other hand, provide information on facility readiness and, in some cases, on service provision and experience of care. And so input and quality adjusted coverage are typically estimated by linking these two data sources. How do you do that? So there's two sort of buckets of approaches to linking household and health facility data. The first general approach is exact match linking. This is where every care-seeking episode in a household survey is linked to or assigned information about the quality of the specific facility that they visited. This is complicated to estimate because you need to ask about the facility names, right, that people visited when you're doing your household survey. Oh, which facility did you give birth at? Oh, your child was sick and you took them for care. What was the name of the facility? What was the name of the community health worker? This is very challenging data to collect, and so it is typically difficult to do exact match linking, especially with existing data. So another approach that has been used is ecological linking, and here care-seeking episodes in the household survey are linked to either an average quality score that might be calculated, for example, within an administrative area, an average across all of the facilities in a region or a district, or there are also nearest provider methods where you link a care-seeking episode to the nearest facility by straight line distance or road distance, regardless of whether that is actually the facility that was visited. Again, you don't know what facility was visited, so you make some assumptions. The question that we started with was, is ecological linking equivalent to exact match linking? Does it give us results that are similar enough that they are usable? So that's the first question that we tried to address. How can we link household and health facility in a way that produces valid estimates? The second general question that we were interested in is, how should we be defining facility readiness and quality of service provision for the purposes of linking? We need one number for quality or for readiness to do this linking. How do you summarize quality or readiness in a single number? So starting with how to link household and health facility data, we conducted two studies in Côte d'Ivoire and Zambia, and then the London School of Makerere University conducted a study in Uganda as part of the EQUIP project that all compared various ecological linking methods to exact match linking for maternal, newborn, child health services. And all three studies reached similar conclusions. So they all found that ecological linking can approximate exact match linking if we account for facility type. So when you do your ecological linking, you need to be, if you're linking to, for example, a facility average, you need to be linking to an average across facilities of the same type that the woman said she visited. And I'll explain that a little bit more later. There are a couple of caveats to this around health facility sampling and non-facility providers that I'll talk about now. So the three studies that I just mentioned were all done using a census of health facilities. And so the question was, do these ecological linking methods work as well when we only have a sample of health facilities? So Emily Carter, who is here today, led a study where using the Côte d'Ivoire data set, we resampled we drew samples of health facilities and we reran the analysis. And what we found was that there is no significant difference between quality adjusted estimates generated using a sample of facilities versus a census of facilities. So the methods work well using a sample of facilities. However, in very specific cases, where you have, for example, preferential care seeking. So as part of this simulation study, we simulated preferential care seeking, which is where people tend to go more to facilities that are of higher quality and are less likely to go to facilities that are lower quality. So we simulated this and we found that quality adjusted estimates based on a sample tend to underestimate exact match estimates when you are dealing with a preferential care seeking situation, especially when your sample size is low. So when you have a situation where there are some biases like preferential care seeking, that may affect your ecological linking results. Non-facility providers now, like CHWs, are typically not included in health facility assessments and may or may not be represented in HMIS depending on the context. And so with most of our existing data sets, we're not able to account for these providers in our linking analyses. And the question is, does that matter? And so what we found is that the impact of excluding non-facility providers depends on the context. In Zambia, where CHWs represented an important source of care for sick children, conducting the linking analysis without accounting for care seeking from CHWs underestimated quality adjusted coverage by 9 to 22 percentage points. In Côte d'Ivoire, on the other hand, CHWs were not an important source of care and there was essentially no effect from excluding CHWs. Another question that we looked at, which is really specific to nearest provider methods, is does it matter if you don't know exactly where a person lives? So with household survey data sets, we don't typically have the exact location of a household. We may have the location of the cluster, and that cluster location is often displaced for confidentiality reasons. And so does having imprecise household location make a difference? Does it affect our linked estimates using nearest provider methods? And again, this work was led by Emily Carter using data from Zambia. And what she found was that in general, having imprecise household location does not affect the quality of the nearest provider methods. However, if you have very high variability in your provider or your facility quality of care scores or preferential care seeking, again, then not having the precise household location can start to bias your ecologically linked estimates. Okay, so now moving on to this question around defining service readiness and quality, and how do we summarize these very complex concepts in a single number. When we started this work, we found that there was limited guidance on summary measures of readiness and quality, and we needed a process to develop these measures from available data. So we used a 4-step process. This has been published around nutrition and ANC, and there will be some more papers coming out for other service areas. So I'm going to describe the process, but if you want kind of more details, because I don't have time to go into all the details, the papers go into a lot more detail. So the 4-step process were, first of all, to identify globally recommended interventions from guidelines, from global guidelines. And then we, for each of those interventions, identified the readiness items and the provision of care items that were needed to really determine whether the facility is ready to provide the intervention and whether they did in fact provide the intervention. And we used intervention-specific clinical and service implementation guidelines to identify those items. We then mapped those items to the questionnaires from global health facility surveys. And then we used that mapping plus quality of care frameworks and clinical guidelines to develop readiness and service provision indices for each service area. So again, I don't have time to go into all of the details of the results, which are very interesting, but I do want to note that the process highlighted a number of data gaps, particularly around nutrition, newborn health, and the human resource domain, in that we do not do a good job of measuring skilled, motivated staff, which is one of the most important determinants of whether care was provided correctly. Another question that we looked at is, how do readiness and quality of care relate? Is readiness a proxy for quality? And the reason we looked at this is because readiness is easier to measure in a health facility assessment than provision of care or than quality of care. And so it is often used as a proxy. We measure readiness and we say, oh, this facility is ready. We're going to assume they have high quality of care. But is that in fact the case? So we examined the association between readiness and quality for ANC and sick child care in 5 countries, adjusting for facility, provider, and patient level factors. And we found a significant but limited association between readiness and quality. So for every 10 percentage point increase in ANC readiness, we found a 0.6 to 2.5 percentage point increase in quality. And for every 10 percentage point increase in sick child readiness, 0.7 to 1.2 percentage point increase in quality. So the effect sizes are significant, but very small. Readiness explained about 10% of the variation for sick child care. And for antenatal care, but not sick child care, we found evidence of a threshold effect. So among lower readiness facilities, there was a stronger relationship between readiness and quality of care. Among higher readiness facilities that already had everything, many of those facilities were not providing good quality of care. Okay, so based on all of this, what are our recommendations for linking household and health facility data? First, we recommend using ecological linking by stratum. This was a method that performed consistently well across studies, is easy to implement consistently in different settings, and is not affected by displacement of household survey clusters. We recommend defining strata based on facility type, managing authority, and administrative area, such as region or district. So for example, a woman who reports receiving antenatal care from a public first-level facility in Sylhet in Bangladesh would be linked to an average readiness or quality score calculated across all public first-level facilities in Sylhet. That's basically how this works. And we recommend using sort of the narrowest available strata in order to link care-seeking episodes to facilities that are similar to the one visited and reported in the household survey data set. Decisions about how to handle care-seeking from non-facility providers are context-specific and should be based on the utilization and service quality of those providers in your context. And where possible, we recommend weighting quality quality scores by facility caseload. I didn't have time to go into this, but weighting by facility caseload improved the quality of the linking, the precision of the linking in these studies. And then just to re-emphasize that readiness and quality are complex constructs that are not usually summarized in a single measure. And so the development of summary measures needs to account for this complexity. We don't just want to throw a bunch of items together. We need to really think about which items belong in these measures in which contexts. Effective coverage measures should specify whether they're readiness adjusted or quality adjusted. And while readiness is important in itself, readiness alone cannot tell us whether service quality is likely to be high. And finally, just to emphasize that we need more work to address data gaps around service readiness and quality, especially around service quality, nutrition and newborn, and in the human resources domain. Okay, I have some references here. Those are all on our website as well, which Agbessi had shown the website earlier. So what we're going to do now is we're going to have 2 more presentations, and then we will have time for question and answer for all 3 of these presentations. So next, I am going to introduce our next group of speakers. Elizabeth Hazel is a global health quantitative researcher with 15 years of experience in reproductive, maternal, newborn, and child health, and community-based and primary care health services, as well as large-scale program evaluations. And she has a lot of experience also in conducting household and facility surveys. Rose Muthee is a statistician and monitoring and evaluation officer. She works at the Division of Monitoring and Evaluation in the Kenyan Ministry of Health, and she is a member of the Ministry of Health Countdown to 2030 collaborative team. Abdoulaye Maïga is an assistant scientist at the Department of International Health at the Johns Hopkins University Bloomberg School of Public Health. He has extensive experience in large-scale evaluations, coverage and quality of care measurement in relation to reproductive, maternal, newborn, and child health, nutrition, and mortality, especially in sub-Saharan Africa. And Helen Kiarie is a health systems and monitoring and evaluation expert, currently heading the Division of Monitoring and Evaluation in the Kenyan Ministry of Health. She has wide experience in implementing initiatives that enhance availability of quality health data in Kenya and other developing countries. Helen leads the Ministry of Health Countdown to 2030 collaborative team. So next, I will ask, I think it is Elizabeth, to come up for the next presentation.
All right, good morning. So I will start by applying this method, thank you, to contraceptive care in Kenya. So again, this is the coverage cascade that Dr. Amouzou went through. And so we've got population in need, likelihood of services, crude coverage, quality adjusted coverage, user adjusted, and then outcome coverage as well. So how will this apply to contraceptive care? So I wanted to show this because we had a little bit of a different interpretation of this for family planning. So for our target population, we've got that's available in the DHSs. It indicates the women are asked about missed time pregnancies and birth in the previous 2 years, whether or not they want to limit or delay childbirth, and whether they're currently using any contraceptives. So we're able to clearly define our target population from the DHS. For our service contact, what we did is we defined it as a woman that's currently using a modern method or was met by a health worker who discussed family planning with her in the previous 12 months. This series of questions is also included in the DHS. The woman is asked, has a field worker, if she's not using contraceptives, all women are asked, including those not using, has a field worker come to your house to meet with you and discuss family planning? Or in the previous 12 months, when you sought care for yourself or for your children, did someone at the health center talk to you about family planning? So that's how we defined our service contact for both users and non-users. The likelihood of service, we really couldn't come up with a good definition for this because demand for family planning satisfied is a contact indicator, but it's also a use indicator as well. We do not have the proportion of women available from the DHS who actually visited a health facility for contraceptive care but did not receive contraceptives, just the way the questionnaire flow is set up. So we instead are going to focus on crude coverage, which is our global indicator, currently using any modern contraceptive obtained from any health source. We're also going to define a crude coverage that is facility-based. Because so many women access contraceptives through the informal sector, through shops, through private pharmacies, and we have traditionally in these measures, we are defining that as readiness 0. We wanted to be able to indicate that our crude coverage, demand for family planning satisfied, and also the proportion of women with their demand for family planning satisfied met by modern methods that are obtaining it from the health facility. So we've defined this crude coverage and crude coverage that's facility-based. And then finally, we've got a quality-adjusted coverage as part of this cascade as well. Is the woman currently using contraceptive source from a health facility, equipped to provide contraceptive services, and did she receive contraceptives with complete counseling? As Dr. Munoz mentioned, sometimes in the surveys we've got this readiness-adjusted quality and the process-adjusted quality as well. But when we only have the readiness available, we can still do the readiness-adjusted quality, which we'll go through in an example in the next slide. All right. So I would like to now invite my colleague Rose to come discuss how we have applied this analytical technique to contraceptive care in Kenya. Thank you.
Okay, good morning. Yeah, so I'll take you through the findings we got from Kenyan data. So we looked at the 2018 health facility assessment and the 2014 Kenya Demographic Health Survey. Though for the HFA 2018 data, the process quality data was not available. So we managed to use the facility type, managing authority, and geographic area as the main units of linking between the DHS and the HFA. So we'll examine the crude readiness and quality adjusted coverage indicators. So for service readiness information in the HFA 2018, so for the readiness score, we were looking at the availability of the modern contraceptive mix. And here we were looking at whether the facility provides or refers for all modern methods, whether it's the pills, injectables, implants, IUDs, sterilization, and etc. Then for the staff and guidelines, unfortunately, this data wasn't collected in the HFA 2018. So for this bit, for guidelines, FP checklists or job aids, and also whether the staff were trained, all this is not applicable. Then for equipment, we were looking at the blood pressure curve, and here we were looking whether it was actually seen and it was functioning anywhere in the facility. Then for medicines and commodities, we were using the 4 contraceptives, the combined oral contraceptive stocks, progestin oral contraceptive, injectables, and the male condoms. So for here, we were looking at whether at least one valid dose was observed and was available on the day of the assessment. So for the service readiness component scores, for the readiness, the total score was at 70%, availability of the modern methods at 60%, then functional blood pressure curve anywhere in the clinic was at 90%. Then for all the 4 contraceptives of interest, it was at 50%. Then for each of them, we had the combined oral contraceptive, whether it was stocked or valid, it was at 70%. Then we had the progestin only pill stocked, 60. Then the injectables at 70%, and the male condoms had the highest availability at 80%. So how did we link the DHS and the HFA? So by facility type and managing authority, for the DHS, we had all the government hospitals, whether it's a hospital, a health center, a dispensary, or anything in the public sector. So those ones were government, were linked to the HFA, where we had the public, whether it's a hospital, a dispensary, a medical center, or a clinic. Then for the private hospital or clinic, it remained the same, whether it's DHS or HFA. Then for the DHS, we had the nursing or maternity homes, the faith-based or church or mission hospitals, and also some clinics owned by the family options. So all these ones were matched to the mission, whether it's a mission clinic, hospital, or a dispensary in the HFA. So for the mobile clinics, community, yeah, I think for the online team, something is wrong. Yeah. Thank you. So for the mobile clinics, or whether it's a community-based distributor or a community health worker, those ones we merge them as in the HFA as the public clinics. And for any other, the informal sectors, whether it's a private chemist, a shop, or from a friend, any other source, we assume the quality was 0. Then for defining the linked units, so for the readiness score, we saw for the urban public hospitals had the largest readiness score at 81%, then followed by the public centers, all the way up to, the list was the urban private at 64%. So for the rural, again, we had the public hospitals having the highest readiness score at 75%. And at the center, we had the rural public clinics, and finally, at the lowest, the rural private hospitals or clinics, yeah. Then for Nairobi, because we actually looked at whether it's urban, rural, or Nairobi, where Nairobi is the major metropolitan area in Kenya. So for the contraceptive method use, based on the KDHS 2014, we saw that the injections were the most common at 44%, while the least were the IUDs and the sterilization, both at 5%. Then for the source of modern methods and current use, for Nairobi, there was no much difference because the private and the non-private were almost the same, 5% and 6%. Then for the rural, the public clinics led at 23%, while the least were the rural mission hospitals or centers at 1%, and the mission clinics at 0%. Then for the urban bit, we looked at the private and the public hospitals tied at 10%, while the least was the urban mission facilities at 1%. So looking at the coverage cascade, so here we were looking at the contact with services. We were looking whether they are currently using a modern method or was met by a health worker at facility for other care or any field worker, whether it's a qualified health worker who mentioned FP in the last 12 months. So for the crude coverage, we were looking at the demand for FP for using any modern contraceptive from any source, the crude coverage. Then crude coverage, we were looking for the facility source, we were looking at the demand for FP satisfied using a modern method, and it was sourced, whether it was sourced at a health facility, excluding all other informal sectors, whether it's assistance, the online, it's popping. It's popping, keeps on. Okay, so for okay, and for the quality adjusted coverage, we were looking at whether they are currently using modern contraceptives obtained at a facility which is equipped to provide contraceptive services, whether it's the method itself and also the counseling services. So we can see from the overall, this is the national overall coverage cascade, and we can see at the contact with services, we were at 81%. Then for the crude coverage for any source at 74%, and this drops to 73% at the crude coverage looking at the facility sources. And this means we are having some women getting contraceptives from other informal sources. The first drop there. Then for the readiness adjusted, we have moving from the facility crude coverage of 63% to 42%. Again, we are seeing this drop. Maybe the facilities they wanted to get the modern contraception from were lacking some of the commodities, or there were stockouts. So that's what the data showed after linkage. So by cascade, by geographical area, again the same sequence is seen. So we are seeing for the rural, the readiness is a bit lower compared to the urban and Nairobi, same as the overall cascade bit. Then for cascade by women's age, again we are seeing for adolescents and women between 18 to 24 years, again they have lower readiness in terms of getting the modern contraceptives. So indicating maybe they are sourcing them also more from the informal sector. Then for the cascade by household wealth, again we are seeing women from poorest households have less readiness, have lower readiness, and they have the lower demand satisfied. Again, this is compared to the women from the wealthiest households. So in summary, we can see that the differences in readiness caused by facility type, the managing authority, and also the geographic areas. Also, again, as I had said earlier, there were two coverage cascade declines. The first one from the crude, any source to 63%, from the 74% for crude coverage for any source of modern contraceptive to 63% focusing on the facility specific, indicating that those women are accessing contraceptives through other sources, e.g. from shops, private pharmacies, and other informal sectors. Then the other one from the facilities crude coverage to the quality adjusted from 63 to 42%. Again, also it shows women are accessing health facilities with low readiness for contraceptive care. And again, this is interesting because we can see they are able to access, but these facilities have lower method availability. Maybe they don't have a wide range for the women to choose the modern contraceptives from, and also maybe inconsistent stocks. We know there may be some stockouts for some modern contraceptive methods. Also, we've seen there is lower readiness in rural areas. Again, the poorer women have poorer readiness adjusted quality for younger women and also adolescents. Then poor women, we've also seen they have less contact with services and lower demand satisfied compared to the women from the wealthier households. So reflections, maybe we can see that the coverage cascade model has helped us to understand the gaps in access, coverage, and quality. Also, it assumes facility readiness is linked with the quality of services. And what is coming up here is that continual stocks is a proxy that the facility is well managed and organized, and also better method availability enables women to make a better method choice, better contraceptive method choice. Also, we can explore whether other readiness core formulas and determine the link with quality of care. Thank you. So I introduce my colleague Maïga to come handle the next presentation. Thank you.
Thank you, Rose, and good morning, everybody. So, in addition, ANC delivery PNC, we are also conducted some effective coverage analyses on IMCI. So these are ongoing analyses, including a dozen of countries, but I'm going to focus on the Tanzania case study regarding readiness and process quality coverage data. So the objective of this presentation will be to describe service readiness as well as service quality, and how to compute IMCI effective coverage accounting for quality of care, which include both readiness and process quality. So this table is trying to summarize the different cascade levels. So IMCIs typically include a broader classification of diseases, but because of data availability and also indicators of relevance, we typically use diarrhea, fever, and symptoms of pneumonia to try to assess IMCI effective coverage. So the first level is to assess the population in need. So meaning that children who had fever, diarrhea, or symptoms of pneumonia in the past 2 weeks prior to the survey. And then we have a first care-seeking level, that is care-seeking from any sources. But the cascade will actually start with the service contact. Service contact, which means care-seeking from health facilities or from a health provider. And then we have a next the subsequent box, which is the service readiness, defined as care sought from a provider ready. And then we have a few intervention coverage for which we assess the crude coverage. And ORS and ORS plus zinc were used as intervention for diarrhea, ACT and antimalarial for fever. And then for pneumonia, we use a service contact. We should have used antibiotic for pneumonia, but data from the sources of data are not really adequate to try to really assess true cases of pneumonia and see whether antibiotic was needed or not. And then lastly, now, IMCI now include all of these interventions. And then we also assess the quality adjusted coverage. That is intervention delivered according to care standards. So this slide tries to provide a summary of the proportion of the different illness with the higher proportion from fever. And also on the right side, we have a source of IMCI care seeking. And as you're able to see in the red bar, we have a high proportion of non-facility or care seeking for IMCI. Okay, unlike to what Rose just presented, focusing on readiness, effective coverage for IMCI, we are going to consider two components of quality: service readiness and service provision. And then for each of them, we are able to see the different components which I include for calculation of the service readiness of the service quality. For service readiness, the main component, okay, which have been used include availability of service, okay, also, sorry. And then also we have equipment, training, medicine and commodities, and the availability of diagnostic services. And for service quality, okay, we use items from assessment of the child health and child health history, as well as item from a physical example of the child, and counseling and treatment. So these are data which are available from some facility survey data like SPA, as I'm going to talk about later. Okay, so putting together all of these different items and data element, we try to assess now what are the score of all of different components. But on this side, this last bar, which is actually that public hospital, public health centers, or private hospital, and then private health center. So as we are able to see, the lower score, okay, across the different components are basically among public health centers and private health centers, meaning that lower level health centers. Okay, we did a similar exercise for also service quality. And for service quality, we found a overall score of process quality, so the process quality of 60%, with the lowest score among counseling and physical example, and a higher score among treatment health and child health assessment. Disaggregating also these different results by source of care, we are able to see where we have a lower score across the different components, which are also similar to what we observe for readiness with lower score among lower level facilities. Okay, for this linking, we use data from a facility survey, which was SPA, Tanzania SPA 2014-15, and then also a household survey, which was the demographic and health survey conducted in 2015-16 in Tanzania. And we carry out a ecological link by region, type of facility, and also managing authorities. And effective coverage was adjusted for readiness and also for process quality. So basically, what we found that when we look at the service contact, okay, for the different diseases, diarrhea, fever, and pneumonia, we see that about 43% of care was sought from a health facility or for a health provider. And then also, when we look at the crude coverage, we had something quite similar of a crude coverage related to ORS that was 45%. Okay, but now also when we look at, there was the proportion of care with a treatment of both ORS and zinc was very low. Okay, it was very low, just less than 15% in average in this country. And also, when we look now, the comparison of likelihood of readiness, so meaning that for about 43% of care seeking from facilities, only 24% of this care was sought from a sources that was defined as ready. And also we see that, okay, quality adjustment coverage was very low in this sitting with just about 16%. Okay, regarding now fever, so half of the case of fever, okay, there was a care seeking from a facility or from a health provider, and the crude coverage was about 61%. So meaning that there was also some care seekings that was a non-facility based. So there was about 11% of non-facility care seeking from non-facility based sources. And then also we see that about 36% of the child have been tested for malaria. And there was not a difference between service readiness and quality adjusted coverage. That was about 28%. But when we look, we compare now service contact and to the service readiness, we see that about 22% of the care seeking have been sought from a sources that was not defined as ready. And also when we compare the crude coverage, okay, to the quality adjustment coverage, we see that also a high proportion, a very high proportion of care seeking have been provided from sources with inadequate processor, inadequate service quality. Okay, same also for pneumonia. When we try to look at pneumonia also, we have a quite similar pattern with half of the care seeking from a facility or health provider, a crude coverage that was similar to the service contractor, and very low service readiness when we compare service readiness compared to the service contractor with about 24% of care seeking for symptoms of pneumonia from facilities which was not ready. And also when we compare the crude coverage to the quality adjusted coverage, about half of the care provider were with inadequate service quality. And then putting together all of the different diseases, we can now see what are now of the pattern now in terms of IMCI. So in terms of IMCI, from out of 100% 100 children with any IMCI disease, about half of them there was a care seeking from a facility or from a health provider. And then comparing also the crude coverage to the quality adjusted coverage, we are also able to see that about half of the services was with inadequate quality, and also similar also to what we can observe comparing service contractor to service readiness. We were also able to assess inequalities, accounting for place of residence, wealth quintile, women education. But I'm just going to present here the example related to the place of residence. So when we look, something that is very interesting, when you look here, we see that in both, we have a quite similar, proportion of care seeking from urban and rural area. But when we look now for the service contractor, we see that a high proportion of care was sought from a health provider or a health facility compared to what we observe in rural area. And also when we compare service readiness, okay, a higher proportion of care seeking from urban area where we've better proportion of readiness compared to rural area. And also we have also, for quality adjusted coverage, we didn't really find a huge difference between we urban and rural area. So just to try to conclude, okay, based on data availability, there is a way to include various numbers of indicators related to quality component or to readiness. But there are some limitations regarding analysis of readiness and process quality for some components like readiness, training, supervision, and counseling. Okay, there was also some limitation, and it is challenging using household service data to try to assess pneumonia or malaria quality. And also something that was a limitation in data, the absence of severity of illness, which is required for classification or admission and referral. For a few diseases that is available, for most of them, these are missing and making challenging the classification of disease severity. So, okay, and also something we also observed that there was a high proportion of non-facility care seeking, as well as also a care seeking from multiple sources from the same disease. Okay, so as that has been presented by Melinda, it's also very important to account for the proportion of non-facility care seeking and to see how to deal with that. Same also for care sought from multiple sources where we use the average score from the different sources in order to assess the active coverage. And also we observed that some discrimination with lower estimate from lower facilities and also large gap between credit coverage and adjusted coverage, meaning that a lot of care seeking have been sought from sources with inadequate quality. We didn't observe a much big difference between readiness and process quality for fever and symptom of pneumonia, but we did observe some difference for diarrhea. So these are ongoing studies, as I said, including a set of countries. And we think that after now going through the different countries, we may be able now to draw more robust conclusion regarding service quality and also service readiness for IMCI. Thank you. Let's move now to the Q&A. Melinda, is it you? Okay.
Okay. No, it's great to see these examples of these effective coverage analyses for different service areas in different countries. What I'm going to do now is ask all of the speakers to come up and sit up here. And we have 15 minutes to answer questions from people here in person and also online. So Elizabeth, Rose, Maïga, and I think we have a mic for up here. Yes? Yes. Okay, great. So we'll start with a couple questions from the audience, if you want to raise your hand. I feel like there's an echo.
Hi, thanks so much for a really interesting set of presentations. I wanted to ask a question that cuts across both the Kenya and the Tanzania case studies. In Kenya, this assignment of sort of, rather CHWs and pharmacies not really having a quality score. And Melinda, what you were presenting where you might have this 9 to 22% drop, when we have such a push to use CHWs in so many places, where pharmacies might be the exact appropriate place for certain kinds of family planning, how can we accommodate or assign quality scores to those sources of care so that we're not accidentally substituting facility quality gaps for, overall quality coverage, if that makes sense. It did seem like there was this huge drop from a 71 or so to 42 or so because primarily of facility gaps in that first case study. So just want to understand your thoughts on how can we start to assign quality scores to those non-facility sources, and how can we really integrate them so that our measurement of effective coverage matches up with how our health system partners are trying to deliver care. Thanks so much.
Yes, if there's any other questions, we'll take a couple.
Great, thanks. Thanks for those presentations. Very enlightening, really interesting work. I think my questions are mainly to Melinda. I'm just curious about this association between readiness and quality. We had unpublished work you probably are aware of from MCHIP about 10 years ago or so, where we looked at readiness and quality together because we had done an observational study. And some things that are really simple, actually there was almost no correlation at all, like hand washing. All the materials were there, but hand washing did not actually occur when we actually observed care, whereas other things were tighter kind of correlations. So I'm wondering if when you looked at these correlations, did you see differences between different services, or were you just kind of taking them all together and looking at it? So that's one thing. And the other is, I'm just also curious about this idea about I saw on several slides the idea that we would take the readiness, and there were different components of it. Was there a trained provider? Was there the commodity needed and other things of that nature? But then you took an average, and I'm wondering, aren't these all fairly minimal things that you need, and the kind of lowest common denominator is in fact actually what the actual service readiness really is, not some average of them? Like if you have 50% trained providers, but you're getting stock-ins, let's say, stock-outs 75% of the time, don't expect that it's an average of those things. It's really more like the highest possible level of service is probably going to be when you actually have the commodities. Whether you have a trained provider or not, they can't provide that service if they don't have the commodities needed. So just curious about your thoughts on that.
Hi, thanks so much for the presentations. This is, I think, for anybody on the panel. I was wondering about the application of this to countries with financial protection schemes and national health insurance, and how looking into things like claims data could help us understand the crude coverage. Thanks.
Sure.
Just want to congratulate Hopkins and the Countdown for a really terrific session, because I think this is one of the deepest treatments of effective coverage I've seen. So really, really wonderful work. I sort of have a macro question, because we've been looking at these cascades of care for many years now, and they're always sobering and disturbing in the poor performance of the intervention. And I think Maïga's work from Tanzania with what 23% quality adjusted coverage for IMCI. If you went all the way to effective coverage and included adherence and outcome, you're probably going to cut that in half again. So the question is, with all of these effective coverage cascades which are being published over the last decade or so, what is the policy response of ministries of health and donors to actually intervening in a systems thinking way to correct or improve and strengthen the system's ability to improve effective coverage? And I think one of the problems is that we call it effective coverage, which sort of blames the intervention. And I think if we call this systems effectiveness, we would focus attention more on the health system, because all of these cascade erosions that occur in the efficacy of the intervention are in the system, in the health system. And we need systems thinking approaches to intervene effectively, not just on one element of the staircase, but in a systematic way that lifts systems effectiveness or effective coverage to the kinds of levels that we need to have the health benefits. I would be interested to hear if you have any experiences in countries who have reacted to these results, because they are really, really serious indicators of the performance of our health systems.
Great. Thank you all so much for these really thoughtful questions. Oh, we have one more?
Sorry, I don't want strong online presence. So I'm just going to let Emily add a couple of questions from our online participants.
Yes, I'm going to be the voice for our virtual attendees here. And just a few questions. One is going to be for Rose around what she observed as kind of the largest gaps in the cascade related to family planning. For Maïga, what our priorities for follow-up with the IMCI study will be. And then a more broad question, I think, tacking on to what's already been asked about how do we go about capturing quality for these non-facility-based providers.
Great, thank you all. So maybe should we start with this non-facility provider question? Maïga, do you want to start, since you were just raising this as an issue?
Yeah, no, thank you very much. This is a great question, and I think that these are also some challenge and issue we found when we go through these different data. But non-facility data, non-facility care seeking issues should be assessed depending on the proportions. There are a few countries where the non-facility care seeking is very low. And in this setting, okay, we can try to maybe not take that into account. But there are some settings where non-facility care seeking proportion is very high, as we were also able to observe in the few slides we presented. But now, as you clearly mentioned, all of these data are health system based. So meaning that these are data coming or collected from health facilities. So there is a lack of data regarding readiness and also process quality from the community, from the non-facility non-facility sources. So basically, what we typically do is to try to assign a score of 0, meaning that the readiness was null from these facilities. We can also assume that the quality of the care was null from these non-facility sources. These are assumptions. Okay, we try to provide, but ideally, it will be great, okay, to also get data related to readiness and also related to quality of care from non-facility sources. As Melinda said, we conducted a study where we were able to collect data both from facilities and also from non-facility sources, pharmacies or CHW. And in this setting, we found that excluding non-facility sources from the score doesn't make big difference than including these non-facility sources. But that was for this case study in Côte d'Ivoire. But when we look in Tanzania, it should be a different pattern where we do have a very high proportion of care seeking from non-facility sources. So far, we use a null score for these sources, but we can assume that this is also some limitation. But the ideal scenario will be to also have a readiness score and quality score also from those non-facility sources.
Yeah, no, and if I can just add for a second about the Zambia study. So what we did there is we had quality of care and readiness information on the community health workers, and we could see that they were actually providing quite similar care to first-level health facilities. So we tried just treating them like first-level health facilities. We assigned children a quality score from a first-level health facility, and that worked quite well in that setting because they were providing high-quality care. In another setting where the care might be less good or where you don't know, that might be a more difficult assumption to make. So ideally, you would have some idea of the quality of your non-facility provider. Or if you're doing your own data collection, go out and collect that data. But it is a challenge. Do you want to add?
No, thank you. That's a very good question. For family planning, agreed, it is a little bit different. There's no diagnosing, there's no assessing. The provider, should provide an array of contraceptive methods, explain the contraindications, help the woman make a well-informed choice. So I think it's worth, and also the private sector, private pharmacies is a big source for contraceptives for women, unlike, child care and other program areas. So I think it's worth exploring. But yeah, our limitation here is the lack of data on the quality. So I think that's something we could see if there are other surveys in other countries that explore this. So I think it's a very good point. Thank you.
Maybe just to add one more point on that. I think from a country's perspective, we have very good guidance on how to do health facility assessments. To assess readiness. Of course, you have routine data giving us the coverage indicators. But for non-facility sources, we do not have any concrete guidance on, for example, if you want to assess the quality of services provided by pharmacies, for example, because they give service to the population, similar to the community level. I think you've mentioned you've done an assessment in Zambia. I haven't seen a specific tool or guidance to do health sort of community level assessment, and I think that's a big gap that needs to be addressed urgently.
Thank you. So I think we have 5 minutes left, so I'm going to move to some of the specific questions for some of our presenters. So Rose, there was a question online about the largest gaps in the family planning cascade. Can you talk a little bit more about that?
Yeah, so for the largest gaps on FP, I think this mainly touches on where the woman is going to get the service, because we have the lower levels facilities like the dispensaries where you'll get most of the modern contraceptive methods being given at that level is mainly the condoms, the oral, the combined oral, and the implants and the injectables. But now for the more complicated like the IUDs and sterilization, you'll get them from the level 3, that is the health centers, moving up to the hospitals. Yeah, so I think that is also a major contribution.
Okay, great. Thank you. Maïga, do you want to talk a bit about the priorities for the follow-up to the IMCI cascade analysis?
Yeah, okay, thank you. Okay, that's also a great question. And I think that one of the points we can try to maybe think more and see how to improve is how to assess maybe assessment and classification of the diseases. This is the first related to pneumonia. So far, data available don't really allow to make a good assessment and classification of pneumonia as a disease from the available source of data. That is one point. Same also for a case of fever with malaria, because we just try to take a proxy which are children which have been tested for malaria. But we don't really know whether these children had malaria or not, and there was a requirement not to give them any anti-malaria drug. Something also that will be also very helpful is the data related to severities of illness, which are very important to try to figure out which cases require some referral or some admission, or which should also be accounted as a case of treatment. And I think that also there are some need to try to improve our data, limited data related to human resource. So human resource is one of the components with very limited data, which are typically used to assess of readiness, but that is not specific to IMCI, but to all of care-seeking, ANC, family planning, etc., etc. Thank you.
Great, thank you. So now I'm going to ask the whole panel to address a very important question that I think was asked around the policy response to these analyses. So what are ministries of health and donors doing with these effective coverage analyses, with these results? Are these data that can be or have been used to address gaps in the system to improve the provision of services or the access to services?
Okay, maybe I'll speak from the Kenyan perspective. So at the Ministry of Health, this analysis, I know they have been done in the past, but I think you're just coming to interact with them maybe over the last couple of months while working within the Countdown Collaborative. And I think the issues that are really coming out are really critical for Ministry of Health and are really eye-opening. And the fact, I think what is coming out is that we have been investing in increasing access to services, increasing service coverage. If you look at our strategy in the Ministry of Health, the national strategy, the subnational strategies, the program-specific strategies for RMSEH, there's a lot of a lot of interventions to increase delivery in health facilities, immunization for children, care seeking for ANC and family planning and all that. But I think what this analysis shows is that we may be having women now delivering in health facilities, like in Kenya, it's now quite high. But what is the gap? At the end of the day, why are our outcome indicators still not really increasing at a good rate? We still have only marginal gains in maternal mortality reduction, child mortality reduction, even from our latest assessment, census or results. And I think what this analysis shows that we have a big gap in especially quality of services as well as readiness of health facilities to give service. And it's unfortunate also that we are also seeing even in our assessments, we have gaps. We are not able to maybe have data. Like for Kenya, we don't have data on some key human resource capacities like counseling, supervision, training, and these are data that we need to see across our health sector, our health systems to see where the gap is. Indicators on quality are really lacking, and I think one of the things I can say in Kenya, we realized when we did the last HFA in 2018, as much as we did a quality of care module, it did not really address the real quality issues that would make a woman deliver in a health facility and still have negative outcomes, either the baby dying at infancy or the mother herself maybe losing her life or having negative outcomes. So we are actually planning in the next couple of months to start a quality of care assessment as a separate assessment, just for us to be able to see really where are we having the biggest gaps. Because I think what this analysis shows is that the quality of care is really an important gap that we can that you can isolate. So I think that's what I can say about that. But as I said, going forward, I think we'll need to also rethink interventions towards now improving the quality of services for those clients who are coming to health facilities.
Thank you so much. Maïga, do you want to add?
No, I think that Helen well summarized this. Just what that, based on what we observe, we should try to go beyond the simple coverage and try to account for the quality of care. Quality of care, which means service readiness and also service quality. Just a small story. When we presented some of these results in a country, country stakeholder was very shocked and surprised to see that and was asking, why are you moving our outcome from 85% up to 60%? Okay, we say that yes, you see some improvement in coverage, but there are still some challenge in the quality of care people are receiving. So you should also try to take that into account. So this result show that we should go beyond the simple good coverage and to account also for the quality of care people are receiving, which are still poor in most of the countries, despite the high coverage.
So I think we are at the coffee break, and we haven't gotten to all the questions yet. So I am going to just, I think the one question that is left is about the facility readiness and quality. And I'm just going to very quickly respond by saying that yes, we did try to look, especially for the child analysis, at association between domains of readiness and quality to see if certain domains were more strongly associated. I don't have time to go into the results now, but I'm happy to talk at the break. But just to highlight, I think what Maïga has been saying, there are real limitations in our measures of readiness and quality. And so part of the reason we think we are not seeing very strong associations at all is that we don't have very good measures of the constructs. Especially service provision is very poorly measured, particularly for children. And our readiness measures really don't measure provider kind of skill or competence, which is a big issue. So addressing that might improve some of this association, but not all of it. Because again, as you said, you can have everything, but still not do the things that you need to be doing. So with that, I apologize. I do think we need to stop and get our coffee and our snacks, and we will come back in 10 minutes at 11:15. Thank you again to all of our speakers and panelists.
It's one of those times in life when you just don't Hi, everyone. If you can start to make your way back to your seat, we're going to start the next part of this session.
Okay. Can I start? Should I start? Yeah? Can I start? Hi, everyone. Thanks for sticking around. Feel free to bring snacks, drinks back to your table. My name is Ashley Sheffel, and I'm going to be leading us through kind of a small group breakout session. So I think, as you can see from our earlier sessions, a lot of work has really gone into developing methods for estimating coverage cascades and applying them in several different countries and in different settings. And as we've kind of come to the end of this work, we really find ourselves coming back to some important questions about the potential uses and really the usefulness of effective coverage cascades. And so I think we as a group often find ourselves asking, for who and for what purposes are effective coverage cascades useful? And or, what can we do to make them more useful for potential data users at various levels? And so today we would like to invite all of you to participate in a bit of a small group activity to stimulate some thoughts, some discussion about the usefulness of effective coverage. So before we get started, I just wanted to say that there are really no right answers to our discussions today. We really want to hear from you all, to hear your thoughts, to hear diverse opinions, and to really just kind of stimulate some thinking and discussion on the ideas of how might we use effective coverage estimates by various users. So I'm going to lay out some instructions for us and then pass out some materials. We also have some Halloween candy as an incentive to stick around, have some nice conversation, get to know your neighbors a little bit for the next 25 or so minutes. And for the people who are in our virtual groups, we're also going to put you in some breakout rooms and distribute some materials. We're going to pass out a Dropbox link, so you'll also have access to the same materials to do this virtually. Okay, so what are we going to do? We are going to ask you to form a group of, 6 or 8 people. We have nice round tables, so you can join either with people you're sitting with or pick some neighbors to sit with. We'll come around to help you find a group if you need some help finding a group to sit with. If you're virtually, we will put you into a breakout group of 6 or 8 people, more or less. And then you're going to receive some materials. In that set of materials, you're going to be assigned a data user role as a group, okay? And we're going to ask you to read through your data user role, read it aloud to understand your kind of assigned role and your purpose as data users for this exercise. And the idea of having this data user role is to really frame our thinking for the exercise, okay? You are also welcome to bring in your vast knowledge of experience from your life as we have this discussion, but the idea of the role is to just kind of help us frame our thinking and to give us a common ground of somewhere to start from. Once you've talked about your data user role and read through it, you are going to review some data. And these are some suggested amounts of time to spend, because we only have, a bit of time. So your group has received some new analysis, which is another sheet in your folder, and it's effective coverage data. So as a group, we're gonna ask you to look at the data and do a little interpretation of the data. Some results are already written out for you, and have a little bit of discussion around the data. 10 minutes or so, not too in depth. And then once you've had a look at the data, you have about 20 minutes for discussion, okay? And we have some discussion questions for you. There's a sheet that has 3 discussion questions to talk about the usefulness of the data for your specific needs as your data user role, okay? And then at the end, we're gonna ask you to take just a few minutes, maybe 5 minutes, to do a little prepare to share. You may wanna nominate someone in your group who may be willing to briefly share some of your group's thoughts during our plenary at the end. It is optional to share back to the group, but we would encourage you, we would love to hear your thoughts. We will also have some other ways to share your thoughts if you don't feel like sharing back publicly as in the group, but we encourage you because we'd love to hear from you. So with that, we're gonna take a few minutes to pass out the materials and to form groups and to set up the breakout groups. We're also gonna come by to help facilitate the group setup, make sure you all have the instructions and have an idea of how to get started, and to answer any questions. Okay? Los grupos.
¿Cuántas?
¿Cuántas personas hay? 23. Entre
Hi, everyone. We just wanted to give you a 10-minute warning. So in 10 minutes, we'll conclude the group discussion right here, and we'll do some feedback to the larger group. Okay, we have 5 minutes now, so 5-minute warning. 5 minutes.
Okay, I think we're gonna try to come back together. We're a little bit short on time, so we're gonna try to come back together, do a little bit of sharing of some of our discussion. Para compartir la pantalla otra vez. Sí. So to start our share back, we're gonna do a little bit something different. And we have a little bit of an interactive approach to sharing back some of our thoughts. And then we'll ask some people to share back from your groups. So we have a Mentimeter set up, and you have two options to access it. If you have a phone or a computer or a tablet, if you go to www.menti.com and you enter this code, or you can scan the QR code, it's gonna take you to a set of 3 questions. So I will give people a chance to scan the QR code before I go to the next slide. Okay, I think most people are in. The link will still be on the following slide, so if you didn't quite get in, you'll still have more chances as we go through. So the first question is, using one word, how would you describe the usability of effective coverage data? So feel free to go ahead and type in an answer, and we should start to see people's responses coming through. So we've got good, somewhat, high, feasible, difficult, complex, informative to an extent, exciting, insightful, can be challenging, helpful, great, innovative, useful, intentional, emerging, signaling, actionable, decision-making, moderate, foundational, need synthesis, complex stories, relevant, thorough, fun. All right, so starting to get a sense of a pretty diverse set of thoughts about how we feel about the usability of effective coverage data. I'm gonna let you keep thinking about it, but we're gonna move a little bit towards our next question, but feel free to keep your thoughts rolling in. Okay, compared to tracking progress in coverage, so this is kind of our previous gold standard of thinking about coverage from a household survey, do you think the full coverage cascade is a value add? Yes or no? Personal opinion. This is our second question. Yes? 100% yes. We got one no. All right, so I think we have some good consensus. There is a value add here. All right, I'll let you keep responding, but maybe we'll look at our next question. All right, so what questions do you have about effective coverage still? And this is really open-ended, a place for you to put in some of your questions that still remain. So feel free to take a minute, write in some of your questions. We'll give you a couple minutes, and then we're going to open the floor for groups that want to take a minute or two to share some of their thoughts about their discussion today, about the usability of effective coverage. We looked at 2 user roles, kind of a national level user role and a subnational level user role. And I heard a lot of really rich discussion, so no one's forced to share, but if anyone wants to share a little bit about what they discussed about the usability of effective coverage, I invite you to raise your hand. We'll give a few groups an opportunity to share. Okay, so I'll just read some of these as they're coming in. So emerging questions. How can it be integrated in the routine HMIS? How to make it more routine and simple? Is the quality of care more important than the crude contact with the health facility? Can you summarize it in 5 words, the elevator pitch? My French speaker, someone help this Spanish speaker out before I make. Okay, the ratio between health workers and users by level. Is the process translatable to all people that need to apply it at all levels in the health system? How practically to do it at scale? How do you do the analysis? Is it easy to implement it routinely? Data sources. How easy to difficult is it to measure? And is it practical for real-time measurement? Who is the primary data user? Is the data timely? How can it be made simpler and user-friendly? Does effective coverage address the challenges from health-seeking behavior in addition to quality at health facility level? How can this effective coverage be adjusted for routine immunization? How to make it more effective and relevant? Are we using the right readiness data? To have this kind of data is very resource intensive. How can it be made part of routine monitoring? How can we best delineate data to inform decision making? Do we need to help people use these data effectively? Guides targeting for resource allocation and interventions to improve quality? How to deal with lack of data that can influence the computation? How to use EC for decision making? How to minimize the impact of lack of data? How to integrate health-seeking behavior? What is or are there applicability at smaller scale, for example, programs and projects? Is there a possibility to see where it has been used and ongoing research questions on the website you shared? Are there questions standardized, or is there flexibility to add more detail if you think it's necessary? How to implement it considering difficult environments such as rural and dispersed areas? Do we need to adapt it? And next up, deep dives. Individual facility level metrics, root cause investigations, correlations between measures, informing decision between improving raw coverage and improving quality and readiness for those already covered. And it continues. So maybe I'll take a minute to pause and we'll let some groups maybe share back some of their discussion. Do we have any groups who want to share back a little bit about what they talked about? One up here? You need a mic?
Can you hear me? There we go. Okay. The good news is I sat down at the expert panelist table, so I didn't have to work very hard. The bad news is they've all exhausted their public speaking for the day, so you have me reporting out for you. So we were given the data use role at the national level. So in our role, in summary, we looked at the data and we noted a couple of things that we just wanted to summarize for the group. Few women were seeking care from a skilled provider. We saw that at 48%, and 12% were receiving care from a not ready facility. We saw an even lower drop for adherence to national standards. Women seeking care there was at 26%. And then we wanted to note the intervention coverage is pretty limited. We saw that as a missed opportunity to stack interventions and services because only 59% of the 48% of women overall were receiving additional services. So in our role, specifically as an HMIS coordinator, our first priority was addressing that whole missing population. There were 52% of the population in need who were not seeking care at all, and we wanted to understand that better. We also wanted to look at the sources of care and experience of care, specifically looking at the, I think it was the public health center and the dispensaries, where the greatest sources of care and experiences of care had the greatest variation. And specifically in our role, because we do have the opportunity to do an annual assessment and contribute to the strategic plans, we wanted to think through how we would target our analysis and target the messaging and possibly provide something like illustrative activities that we would suggest that would help tackle the issue, kind of being the bridge between the data and how that would actually be implemented in real life. And then, of course, also weighing in on the strategic plan priorities, especially as I think we were halfway through the strategic plan. We looked next at the barriers to using data, and the first and foremost was political resistance to what the data might say. I think this is a very real issue in a lot of places. There are conflicts of interest in how you interpret the data and what the findings are that might be pretty limiting. And then we also talked about coverage can sometimes equal more money and how data might betray funding priorities, and we need to think through, again, how we interpret it and how we present the findings so that we can actually move forward with the information. And then the last thing we noted was some of the facilitating points, is that data is an opportunity to answer very specific questions and inform broader decisions about care gaps that we might be seeing. And I will defer to the panelists if I've missed anything.
Thanks very much. Any other groups interested? Yeah?
Okay, thank you very much. In our group, we discussed a lot. We discussed a lot about even the whole health system at district level and at national level as well. And finally, we conclude that principally the first figure, which is showing this cascade, this is an excellent eye-opener, which showed the first gap we are seeing, which is the crude coverage, and then we have all the cascade to go to the quality. So this is something very, very good at any level of decision making as eye-opener. But we noticed that the diagnostic tools we have are tools which can be built using the routine HMIS data. Normally, we are supposed to have this, and we have this data, this information in the routine HMIS data. So what's unfortunate is that this analysis is actually not done. So it's not a kind of, this effective coverage is not adding anything. It's something which needed to be done. And just for this specific question, it's something which needed to be done. So what's now urging is to push countries to have this. So to have the subnational dashboard, to have all this and use them for decision making. We have noticed many, many barriers, and I think all of us, we know them. When you are talking about routine data, we have this first time difference between the action when you want to put an intervention and the results, which make it difficult to assess the results, to assess the impact of your intervention, and principally when it goes to health system. So it would be difficult to say, okay, because of this particular figure, we made this action and this solved the problem. So for decision making, this sometimes very hard to do it. We know, all of us know the problem of the quality of data, principally in the low middle income countries. We are still struggling on that. And this absence of this kind of information. But generally, we have noticed that the information which are being provided is very important to improve the quality of care. It's very important, like for budget allocation, to know where to allocate the money, where to put more effort, and so on, in order to improve the quality of care, and even according to who's going where to seek for care seeking, to know exactly where we are going to put it. So this will even improve the gap between the 48% and the 26%. But we are still thinking that what's important is to have access to the health practitioner, to the health professional. Because even though he doesn't have all the material to provide a high quality care, but you need at least to have access to him, so he'll be able to diagnose and even give you good advices and so on. So we think that this activity needs to go further in order to improve the demand, because this is just limited to the offer, and the demand is still important in our context. I don't know if I've been okay. Thank you very much.
Thank you. I'm told we have 2 minutes left, so maybe time for one more group to share.
Hi, can you hear me?
Yes.
Kate Gilroy, JSI and Momentum. So just really quickly, and some of my group is indisposed, but I think, we took a little bit of time to unpack the data, especially in the Cascade, and we were district level M&E officers in our assigned kind of scenario. And we kind of found some of the data below, which I believe are elements of what goes into the effective coverage, from the readiness, from the quality assessments and those, and from the first graphic too, which I believe is from probably the DHS or the coverage. We found those a little bit more useful actually to kind of maybe make decisions. And just wondering if there's some way to present that, the Cascade in some way that could show the proportion of readiness, quality, and coverage that's driving the final estimate of we had 26% of the effective coverage, to kind of help a district level manager make that decision on where to prioritize. Because some of those, the quality, readiness, and coverage would actually have different decisions or different actions that are needed to drive those up. And then also just, since we were at such a low level, just thinking we would want much more disaggregated data, kind of by the facility type, so we could see where we would need to take those actions. And then just similarly to what other people were saying, I think maybe even triangulating or bringing in some of the HR staffing and the throughput, the LMIS and stocks, and some of those kind of more routine measures to know kind of where to put your, and if you have a human resources for health information system, like the staffing plus the training, and kind of to know where to deploy or take some of those actions or decisions, and maybe, you know, at that low level, kind of triangulating some of this data or bringing in other data to try to figure out where to take those actions. I think, yeah.
Thanks very much. And I'm sorry we didn't have time for all of the groups to share, but if your team has notes you either want to put into the Mentimeter question, or if you have just written notes you want to share with us, you know, we're really interested in kind of our next phase of understanding how do we take this forward to make it useful at country level, and we'd be really interested to hear from all of you guys on what your thoughts were today. So please feel free to share anything you want with us. We'll be happy to take it. And with that, I'm going to pass it over to our next set of presenters, which I believe Agbessi is going to be leading, and with our panelists.
Now, piece of this session, and invite our panelists. We have a distinguished panelist that we would like to invite to the front to start a few discussion again around a number of questions, some that overlap actually with some questions I saw on the Mentimeter. So, Dr. Lara Vaz, I think Lara is here, right? Is a senior program director at Population Reference Bureau in international health programs, and serves as a technical director for the Momentum Knowledge Accelerator project. She has more than 25 years of experience with public health program planning, implementation, research, and monitoring and evaluation in the United States and globally, including work on the PEPFAR and maternal, newborn, and child health programs. Then we have Professor Tanya Marchant, Professor of Implementation Science at the London School of Hygiene and Tropical Medicine. She's interested in how to improve the effective coverage of high-quality reproductive, maternal, newborn, and child health care, primarily in sub-Saharan Africa. Her work has included investigations in women preference and priorities for fertility control, testing delivery strategies of insecticide-treated mosquito nets for the prevention of anemia and malaria in pregnancies, and quality improvement for maternal and newborn health care. We have Ms. Claire-Helene Mershon. Where's Claire? Okay, yeah, you are here already, okay. Claire is a program officer on maternal, newborn, and child health team at the Bill Melinda Gates Foundation in Seattle. Her portfolio focuses on data and evidence for decision-making. This spans both identifying population vulnerable to poor health outcome, and understanding and integrating their needs into projects, and strengthening measurement, monitoring, and data availability and use for MNH and maternal, infant, and young child nutrition in countries and at the global level. And we have a fourth panelist, Helen. Huh, come on over. We already presented Helen. She's again, a health system and monitoring and evaluation expert, and currently heading the Division of Monitoring and Evaluation in the Kenyan Ministry of Health. And so, here are our distinguished panels. I'll just ask you a few questions on, the effective coverage and everything we have been discussing so far. Since we're running out of time, I'm just going to run straight in. So, Dr. Vaz, you have extensive experience in program planning, designing, and especially data use. And can you tell us how is quality-adjusted coverage or effective coverage, and how is it helpful as you assess what aspects of a program need improvement?
Thank you, Dr. Amouzou. I think that's the first time I've heard you call me Dr. Vaz. And my sister is actually Dr. Vaz. I tend to be known as Lara. But anyways, I think effective coverage is a really great next step that we've taken from the cruder coverage pieces, and it helps us unpack. And I think from a program perspective and a data use perspective, we really need to better understand what we're trying to do and what we're trying to achieve, and then work backwards. So we often start by looking at our mortality and morbidity profiles and then trying to then say, oh, we are trying to reach effective coverage. But in order to understand what have we done with effective coverage, we need to then unpack it to understand where the points of change need to occur. Mm-hmm. And I think that may occur at a program planning phase, that may occur as you're implementing, and that may occur at an evaluative stage or when you're revisiting a national strategy, or even at a subnational level when you're planning your annual budgets. And so the kinds of information you may need are really important with quality adjusted coverage. And I think one of the discussions we had during our small group sessions that is really important, that is it's an additional piece of information that we have that needs to be used with other pieces of information. And it's really important to look at that within the context of your health system and your health service delivery, which may be through your public sector, through a private nonprofit sector, but also increasingly through private, formal and informal sectors, and in a context where we're seeing also a focus on self-care. And we don't talk about that. And so if the facility is ready and is delivering the service, is that enough? Do we understand what motivates somebody to go to a facility versus someplace else? Do we understand from the provider perspective what motivates them to provide that overall service, or the multiple interventions that are often hidden under something like antenatal care at that time when they should be delivering it? And so understanding the volume of service, the levels of fatigue that may be occurring, particularly in the context of COVID-19, the allocation of resources, the policies that are available. I think those are all really important, and I think that continuing to keep the entire health system in mind, regardless of where you are, is really important. And what piece of effective coverage you need to look at that particular point is very much a function of where you sit on the system, as well as what decisions you need to make at what point in time. Are you trying to make changes in the immediate, or are you trying to make changes in the long term? Thank you.
Thanks very much. Here I heard in the next steps, I heard unpack. So as we try to measure gap between contact and quality or crude coverage and so on, we don't stop there. We need to then unpack and find out
Unpack and triangulate. Right. I think that's really important. We should never be looking at one piece of data in isolation from everything else, and it shouldn't just be quantitative.
Right.
Understanding the context and understanding what is going on is as important as looking at the number.
Thanks very much, Lara. Now, let's go to the country. We have some questions, interesting questions here before, especially on how the countries are responding to this in terms of policy and so on. And so, Dr. Kiarie, you are the expert country person on the panel, and you know, heading many monitoring evaluations, interacting with decision makers and program implementers. So how does this resonate with the implementers in the country in terms of incorporating you know, quality in the coverage? Because they've been measuring coverage, and now we're going back and saying, oh, this is not good enough. You need to make sure that quality is incorporated and then monitor both. So are there instances in your country where this really has been taken up?
Okay, yeah, I think this data has helped us to uncover quite a bit of issues. As I mentioned earlier, you know, all along we've been having all these trends showing increasing immunization, increasing deliveries in health facilities, ANC coverage. But I think what this shows is that we are not yet there. We may be having all these services that we are providing to our population, but then there's still the question of why do we have stagnant or marginal gains in terms of overall outcomes? Because if you look at our for example, maternal mortality, we are still you know, not sure whether we are not really making good progress. There's progress, but it's not enough. The same happens to child mortality, especially neonatal mortality, which actually talks more directly to quality of care. Indicators like fresh stillbirths, again, which point directly to gaps in quality of care. So what we have, what this shows for us in Kenya is that as much as we are advising mothers to come to our facilities, we are still having crowded health facilities. You know, mothers will come and maybe you'll find 2, 3 mothers sharing a bed with their babies. And of course, this also means the nurses or the staff taking care of these mothers in these health facilities really cannot cope with the you know, giving quality service. So you have this shows a lot of issues, especially in terms of even motivation of staff, both in terms of financial motivation. Are they paid well? Are they paid on time? In Kenya, we have devolution, and we have a lot of issues that could be leading to all these issues, all these gaps. You know, even delay in a salary. I'm sure if your salary was delayed for a month or so, you would start feeling some frustration. And these are some of the issues that can actually lead to someone, you know, attending to a mother maybe in labor and not really giving the best care. So the issue of unmotivated staff is really something you need to investigate. And I think we are slowly starting to put these kind of issues into our policy documents, interventions, and I think this will also be helpful next year when we come to you know, putting together our next strategy. So I think as a country, we are now thinking of moving out of just increasing the coverage and moving more into improving the quality of services that people access. The other gap that we have seen is the data availability, especially on the quality of care. So we find that, again, issues of quality of care and patient-centeredness, because again, we may be giving all these services, but many times you don't think about the patient perspective, and that's really important, because even if the patient gets the best care in that health facility, if for one reason or the other there was a gap in even giving the service according to standard protocols, and that also incorporates advising the patient, making them part of their care plan, that really determines outcomes. And I think these are some of the issues we have started to incorporate both in our strategies, interventions, as well as monitoring in our M&E plans. And if you look at our current M&E plan, we actually have some indicators on patient-centeredness. And I think some of the guidance also coming from the global level, like the PHC MFI, the primary healthcare monitoring framework and indicators, has a lot of focus on some of these issues, incorporating even things like patient safety surveys, which we have not started, but we plan to cumulatively add this kind of assessments into our future plan, so that we can actually know where we are, not just in terms of how many people came to the facility, but also the kind of care we offered, and also how good was it from the patient perspective.
Thanks very much. Very, very insightful. I wanted to, to push you a little bit more again on this. I mean, you are the head of the M&E, and here are we coming up with additional indicators. We are saying what you have now, it's what we have now for coverage monitoring is not good enough, because we're talking about coverage and we're talking about quality, all very important, and we were trying to join both. So within your M&E framework, are people open to the kind of indicators being incorporated and monitor going forward?
Yes, I think in terms of health workers, especially M&E and health information staff, the reception on this has been very good so far. Of course, it was a little bit difficult to conceptualize at the beginning. For example, what are patient-centered indicators? We really garbled, Googled, and everything. So we came up with a few indicators, but I think it's becoming more and more clear to us, and also to people we work with, not just M&E staff, but also other technical and senior management. So of course, it takes a bit of time. I think it's something that we started maybe in the last 2 years or so. And we expect that reception will, so far the reception on this aspect is quite positive. In terms of quality of care, this is really highly appreciated, but measuring quality of care has been an issue. We usually have more of systematic health system indicators on quality of care. In many cases, do you have a quality improvement team? Do you have meetings? Do you have, all these kind of indicators? But in terms of the quality of service that the patient receives, I think this has been a gap, and I think this is the value add of this analysis. It actually incorporates the quality of care indicator into the service delivery performance sort of tracking, and we can be able to see with time, are we giving increasingly better care to our clients? And I think this is something that is going to be very insightful. If you look at our reports, including our medium-term review report for 2020-2021, we do not have effective coverage, unfortunately, in the analysis. But I think going forward, this is something we will aim to get. And I think I'm also looking forward into having the analysis being able to, have these sort of analytical methods available at country level for easy implementation and incorporation into routine sort of assessments. Because what we have seen is we are using survey data. Some of the survey is quite old. Our latest DHS was in 2014. I think we're expecting to get the ongoing DHS results, key findings in December. So I think in January we should have some updated analysis. But I think going forward, because the way we work, we have all these annual health reports, we would like to see, are we able to do effective coverage analysis using our DHIS data? I think that will be a good addition, so that, as you're saying, doing the trends, the yearly, annual trends, we can actually incorporate effective coverage into these analysis. So we are hoping, I think we are among the ones who are asking, is it possible to have this incorporated into routine analysis?
Great responses. Yeah, because we want countries to really, as Lara was saying, contextualize this and come up with the key indicators that they need based on the need, because we don't want countries saying, oh, these are another indicators being pushed on to us to monitor. But Professor Marchant, you have extensive experience in doing this kind of work. I remember your work in Nigeria, in Ethiopia, in India, and so on. So going forward, what role do you see effective coverage measure playing in monitoring evaluation, both at country and at global level?
Thanks so much, Agbessi. It's kind of hard to follow Helen as well, and I'm kind of going to go with my own script because I don't want to just say what Helen and Lara said. So I want to try and make sure I represent some of my thoughts here as well. Well, I do think it's an exciting time. I have, as Agbessi says, I mean, my hair color is really different to that. I have been working on this for a really long time. And it's an exciting moment because we are at the point, I think, of almost realizing the potential utility of effective coverage measures. I think I've seen things happen. We've got a concrete focus on quality now. Nobody disputes the need to engage and invest in improving the quality of care. There are new innovations in digital data. We've got much better methods research, hearing from the Improve project earlier. And crucially, I think we've got much more focused emphasis on country leadership for generating and using these measures. And that really shifts us forwards in quite a substantive way. So it's a good time now to be more clear about what they can do for us, because I don't think they can do everything, and being clear about what they can do is important. And I see that there's a little bit of tension still in the extent to which an effective coverage measure can drive quality improvement and the extent to which it can help us track progress. And I just want to explain a little bit more what I mean about that. So on the role of effective coverage measures for driving improvement, I mean, it's indisputable that programs need data on quality of care that they're providing. So the work of Countdown to generate these sorts of measures across multiple countries and at scale is really very important. But I think when we're thinking about how the measures are going to be used, we have to think about what's the level of use at which the action will be taken. And it's nearly always going to end up being in a district or in a facility itself. And improvement actions in facilities, they need really detailed engagement at the local level. But an effective coverage measure is a really convenient composite. You've aggregated a lot of information into a composite measure, which is very efficient and helps with communication of the problem of a quality deficit, if there is one. but it's quite hard to take action on it. You just know that you're, we were a national manager in the exercise earlier, and all we knew was that just a quarter of our target population were receiving quality ANC. If I'm in a facility and I want to take action on that, I'm going to need to use local information in real time. So I'm going to need to disassemble that composite effective coverage measure in order to make decisions about action. So for me, when I'm thinking about program improvement, effective coverage measure overlaps with bottleneck analyses. And I think I was talking to Don de Savigny when I came in this morning, and he was saying there's this thing about terminology. We have all these different phrases for the way in which we want to use data to drive decision making. And I think that we can do better in standardizing some of that terminology. But essentially, problem solving through data and having the different steps in the cascade is helpful. So understanding, do we have a problem with inputs, and if so, which? Do we have a problem with intervention delivery, and if so, which? Do we have issues with behaviors of the providers or the users, and if so, what type of behavioral issues do we want to address? So I think increasingly or certainly for program improvement, we need to be focusing on local decisions using local data. But the effective coverage measure helps to shine a spotlight on where we need to be looking. On the other hand, for effective coverage measures for tracking progress, I think there's ready for us to, we should be running with this now at the subnational, at the national, and at the global levels. I think it's a really great opportunity now to be doing more. But there's something very specific that I think we all need to come together to do to unlock the potential. And that's that at the moment there's huge heterogeneity in the definition of the indicators and in the methods that are used to construct the measures. And it's very important. We've spent decades making sure that our crude coverage measures look the same everywhere, so that when countdown measures for ANC, it's the same as when the Ministry of Health in Kenya measures for ANC. It's the same as when WHO measures. It's the same when my research project measures. We've got trust that when somebody reports coverage for ANC, it's the same everywhere. And we don't yet have that trust with effective coverage measures. And I think it's a job that we can do to try to construct a core set of effective coverage indicators that won't be as comprehensive as we might like, but that are simple and transparent, that we all know what goes into them, and we can compare then progress between time and place. And I'd love to see those just consistently and systematically being presented alongside a core set of crude coverage indicators so that we can continue to exert pressure and accountability for investment to close the gap, because that's what this is all about. It's closing the gap to make sure everybody who accesses care accesses the best quality of care that's available. Yes, I think I should pause there.
Excellent. Very, very excellent point. And the distinction between progress tracking, quality improvement, and you know, how these relate to the interpretation of the effective coverage measures. I don't want to forget, you know, Dr. Kiarie asked a question about how do we incorporate routine health information into this. I mean, because this is what countries have as data ready, real time going forward. And so how, and I know you've been thinking about that as well. So any thought on how this can be useful in effective coverage?
Yeah, thanks so much. And I mean, I do feel really strongly that once we've got sort of we're clear about how we want to use effective coverage measures, and we're clear and transparent about the definition of them, then the next step in the process is thinking, how do we make this routine? And it was absolutely brilliant when Ashley was displaying all of the comments that were coming in from the room. That seemed to me to be one of the #1 questions. How do we do this more in real time with routine data? And I just think it's an imperative, it's a must that we actually get better at using routine data. Countries invest huge amount of money in their own data systems, and they trust their own data systems. They want to use their own data systems. One of the big problems, of course, is that routine data systems don't tend to have They can have quality issues. They might not be complete. They might not be, the reports might not be complete. They might not be made on time. There might be missing values. But if we hardwire them into decision-making processes and raise their prominence and start to use them, it has to be a win-win situation. The more they're used, the more important they become, the more investment will be made, the better quality they will be, the more sustainable it will be going forwards. But the other reason why I think it's really important to be thinking ahead to using routine data for effective coverage measurement is that it's more timely and granular. So that issue that I see, the limitation of effective coverage measurement for program improvement, can be addressed if we shift to using routine data sources, because then you can generate the measure for your facility in real time. And for that to happen, I think, and this is my last point, we really need to be pushing for investment in people, the capability to use data and interpret data at subnational levels, as well as the tools. Yes, we need the tools, but we need the investment in the capacity of personnel to analyze data and make decisions with it, alongside helping as a community to harmonize the measures so that there's a growing trust in the data that they're using. Thank you.
Thanks very much. So, Ms. Mershon, as a donor, right? We like donors. So how do you see this effective coverage measurement play a role in tracking progress, at global level and generating evidence for you to use to maximize your return?
Thank you, Agbessi. I'm going to try to limit the déjà vu and the repetitive comments because I agree with a lot of what has been said up here. But within the global agenda for MNCH, we have global and national targets for maternal and newborn mortality reduction. And to achieve those targets, we need to increase the number of mothers and newborns who are accessing high-quality health services. Globally, we have the Ending Preventable Maternal Mortality Strategy and the Every Newborn Action Plan, and they're setting targets for coverage of ANC4+, skilled birth attendants, and early postnatal care. Within that, there are also milestones to help countries track whether they have the necessary components of a high-quality health system in place, without which they cannot achieve these targets. And it's important to note that having these in place won't necessarily lead to reaching coverage and outcome targets, but without them, the targets can't be met. And on a smaller scale, I see effective coverage measurement as providing a model for measuring the health system components that are necessary to go from access to intervention to health outcomes. Reaching 100% in each of the domains included in the effective coverage cascade isn't going to result in achieving mortality targets, but without improving each of the pieces of the puzzle, we're not going to see improved outcomes. And I think that's one of the really exciting things about the effective coverage model. Not only do we get sort of a composite indicator of effective coverage of interventions, but it also takes into account multiple dependencies of the health system, like access, health systems readiness, commodities, and effectiveness of the interventions as they are delivered in the real world. And this helps us identify the areas across the cascade that are falling behind. At the global level, this helps us prioritize decisions on research, resources, and advocacy. And it also informs global tracking of interventions and gives us a clue about whether the intervention coverage is actually going to improve outcome targets. The global measurement agenda for MNCH, as Tanya talked about, has matured significantly in the last 10 to 15 years. And we've improved the way that we measure coverage or counting of contacts, but it's understandably led to a lot of questions about the content and the quality of these services. As we learn more about the importance of quality services and their impact on outcomes, we've been able to identify the ways in which we can better measure quality of services, and effective coverage measurement provides one way to do that. And also talked about the measurement improvement agenda. And as you've seen here today, groups like Improve and Ideas and the Saving Newborn Lives project have done a lot of work to improve how we measure key MNCH interventions. But as you saw this morning in the presentations, there are still areas where we need agreement and more evidence on how to measure the components of effective coverage. And this can vary between interventions, and that also gets into the equity question. So it will be exciting to see how we can use tools like linking to understand equity gaps and dig into some of these questions through effective coverage measurement models. But finally, I want to say we need to keep in mind that indicators indicate. At the global level, we don't necessarily need the metrics for every single intervention or every piece of data on demographics or health systems readiness. But we do need to know enough of the right data to be able to bring attention to the things that are or are not working well. And MNCH in particular has a lot of really valuable metrics that can provide meaningful indicators of how effective a health system is, whether it's meeting the needs of its users with sufficient quality and equity to influence outcomes. But I think effective coverage measurement provides a great tool to help us get to some of those goals. Thank you.
Thanks very much for a comprehensive and very informative response on this. I'm looking at the time, right, and we're getting close to the hour. Well, one important aspect that we have mentioned, but not mentioning good enough, is data availability, right? Because we have been able to do these things based on the scant data that we have on facility surveys, the SPA and SARA. Not many countries have those, and not all countries collect those regularly. So in order to be able to do this, it's important that we invest in data collection to measure quality that can be linked to coverage, right? So critical also is the routine data that we need to take advantage of. The data are not necessarily collected on quality information that is needed. It's still limited, but we can open up and see what is the way forward for that. Well, we have 3 minutes. I just want to give to the audience one opportunity for one question or one comment or two, maybe if you can afford to stay a couple more minutes, around what you have heard on the panel and anything, any insight or any something burning in your gut. You say, I got to get this out. So, right? Anybody?
Good morning, Bruno Boucher from Chemonix International. Let's say this concept, these methods, these indicators do not exist, which is almost the situation now. We're just at the beginning of exploring and measuring effective coverage. So what do we have? We have utilization, coverage, data from routine health information system, a proxy for accessibility to healthcare services. And then we would have, from time to time, when a donor is interested, a survey on quality of care. And the results are always the same. For the past 25 years I've been working in this field, the results are always pretty bad and disappointing, obviously, right? So when we put the two together, then we get what you call effective coverage measures, and it allows to draw this cascade, this graph with the cascade, which shows all the owners of the health system, the stakeholders, where the gaps are, where the losses are at each step of the process of care, from access to the health outcomes, basically. And so that's the value for me of measuring effective coverage, because each gap that you have mentioned in the framework that you presented at the beginning has different type of root causes and is questioning different features and functions of the health system. And of course we need now it's a starting point for systems analysis, for systems improvement, for redesigning the health system and making changes in the health system. So this is for me what I'm getting from this session. I think it was terrific, and that's the value of effective coverage. But that's just a starting point for systems improvement and health system strengthening.
Fantastic, fantastic. Thanks so much. one last intervention. 2 minutes, or maybe what?
Thank you.
Well, you have 1 minute.
1 minute.
Sorry.
Yeah. Thank you very much. I just wanted to say that I'm Serge Somda, health information expert at the West African Health Organization. I just wanted to say that for me, the take-home message is what Professor Merchant said. Now we need to invest in the people, because we have been building many indicators. We have been building many technology, techniques, products, and so on. But people are not using it, or they are not using it effectively. So what we need now, including this new vision, which is amazing, what we need now is go back to people at the more disaggregated level, at the grassroots level, and try now to get them use effectively the data to take good decision and now start escalating. So thank you very much for this panel and all the tasks.
Thank you very much for participating in this session. We think we've been very productive. I think we're making the presentations available for people, and so some link will be sent out or already available for people to download the presentations. And you want to come over to close? All right, okay, thanks so much, everybody.
We may need to adjust the height here again. It's a, thank you. All right, so I'm the only thing standing between you and lunch, so I will be quick, but I did want to take the chance to thank all of our presenters, our panelists, and our moderators. Really great presentations and discussion about where we are in terms of effective coverage estimation and use, where we need to go from here, and how effective coverage can be used potentially to improve access, quality, and health systems performance and outcomes for the patients. I also want to thank George Munya and Emily Carter, who helped facilitate our online session for folks who are online, and also to Shelley Walton and Brittany Fergal, who helped make this session possible and really did a lot of work behind the scenes. And then finally, thank you to all of you for coming, for staying through quite a long session, and for really participating very actively, giving us your thoughts, your comments, your suggestions and questions. It was really valuable for us to hear from you, and we hope that you also found this session valuable. Thank you all.
All right, come on up then.